Everybody's awake, so we'll start a very interesting rapid-fire session, and I'm with my co-moderator, Jill Balatin from Israel. So I'll just present the first speaker, who's going to speak about enhanced endoscopic harvesting of the great saphenous vein for cabbage using hydrodissection. This is Mr. Gallagher.
Good morning, all. First of all, I'd like to thank the Congress for the privilege of presenting our data. The names of all my co-authors are on the abstract in the program. Although I don't have a disclosure slide, I'm happy to report that our group is joining forces with the Arthrex Corporation to develop a prototype hydrojet dissector for performing the MINT procedure. Let's see if we can start this. Lima to LAD is the gold standard for bypassing cabbage with a 90% 15-year patency rate. In the United States, the GSV harvested by EVH is the second most common bypass, since it eliminates leg wound healing problems. This is despite the significant problem of vein graft failure, as high as 25% at 1 year and greater than 50% at 10 years. What is needed is a minimally invasive harvesting technique that incorporates the best features of both of these conduits, the MINT procedure. The MINT procedure utilizes hydrodissection to harvest the GSV in an atraumatic fashion, much like fragile neurovascular bundles are mobilized for pedicle flaps in reconstructive microsurgery. The technique allows the harvester to avoid the 7 major problems that occur with currently existing EVH technology. These 7 problems are blunt trauma to the GSV, a steep learning curve, macro and microthrombi on the endothelium of the GSV, bleeding secondary to systemic heparinization, spasm of the GSV, thermal spread from bipolar cautery, and the toxic environment from non-humidified acidic carbon dioxide. This short video will demonstrate how this is done. See if I can get it to turn on.
Below to the left. No.
How to...
At the bottom, yeah.
Good. So a standard EVH device is modified and used off-label to perform hydrodissection. Instead of blunt dissection to clear the soft tissue surrounding the GSV, the tissue is gently hydrodissected off the GSV under direct vision. The hydrodissection fluid clears the soft tissue before the instrument ever touches the GSV. This keeps the GSV essentially under direct vision at all times, so the harvester is moving from known to known rather than from known to unknown. This essentially eliminates the learning curve. The fluid used is Plasmolite A with heparin and papaverine added. This fluid has an ideal pH of 7.4 and delivers pharmacologic concentrations of heparin and papaverine to the endothelium of the GSV. This eliminates clots and spasm and keeps the eNOS enzyme system at the ideal pH for maximum function. The high specific heat of the fluid greatly reduces thermal spread from bipolar cautery. Let me turn this. How can I turn this off?
Go to the next slide. Page down. Yeah.
Okay, yes, it'll work. It works, great. So this approach results in a great saphenous vein with an endothelium that is a perfect cobblestoned appearance. We've done a pilot study with 24 patients. 17 patients underwent the MINT procedure, 7 standard EVH, and all 24 had standard no-touch done. With this procedure, we've been able to demonstrate that the eNOS activity in the MINT-harvested great saphenous veins is 3.4-fold higher than any other known harvesting technique. This is a massive increase in nitric oxide production and might represent the most structurally and functionally intact endothelium in any harvest to date. So as a result of that, we are currently coordinating a collection of CT angiography on the first 10 MINT patients that were done over a year ago. Hopefully this will demonstrate improved patency over standard EVH as suggested by the scanning electron microscopy and eNOS data that we've presented this morning. Thank you for your attention.
Thank you very much. Since we passed the 4 minutes, we will do maybe discussion in the end. Thank you very much.
Okay, thank you.
The next rapid abstract will be from Dusing Kim from South Korea. Similar 10 years long-term survival outcome result between on and off pump cabbage in left main disease patients.
Thank you, Chairman. Good morning, ladies and gentlemen. I'm Dr. Kim from South Korea. Nothing to disclosure. As you know, the left main is a very severe disease condition, 20% mortality in a year if no treatment anywhere. And recently, popular CCTA examination, more than about 50% insignificant left main is incidentally detected. It is need to follow next 5 years. It is to define it is severe or not. So this study is to illustrate between the on and off pump cabbage result about the left main disease. As your personal experience during the time period, we have 130 group 1 on-pump cabbage and 111 off-pump cabbage patient. Study endpoints is all-cause death, cardiac death, and composite MACE. All-cause death is, in Korea, the cancer is #1 killer, so cardiac death is more reasonable to define the result. As you can see here, between the two groups, the most important difference is age. About 13-year difference. It is quite different. The others is not significant. This is one case. 80 years old female patient. He suffered the chest pain. Left main 2 vessel, moderate AS. We conducted the full stenotomy OP cap. Skeletonized all conduit with harmonic scalpel recently. And after the made bypass, the pericardial closure. Usual operation time is about 6 hours. Transfusion is only 1 PET cell. Post-op 1 day, expect and move to the general ward. And chest tube removed the other day and discharge within 2 weeks. Peri-op characteristics you can see here. It is quite different time period. So the ICU stay is quite shorter in OPCAP group, and number of anastomosis is very little difference, but it is still statistically. The other is not important. The morbidity is, you can see, is quite high, but I think it is more improving nowadays. The all-cause death, cardiac death, and MACE is not different between two groups. As you can see here, survival function. So my conclusion is the on and off pump, in spite of the different time period, in spite of the quite severe age difference, there is no difference in the clinical data. Thanks for your attention.
You were right on time. Any question from the audience? Yes.
Yes.
One question.
One question, just.
Hi, I'm Perro from Montreal. Did I read right? 26% complete revascularization in the first group? 26%?
Can you show the slide? Complete revascularization. So some different, but I think good. I will later in detail look again at this.
Thank you so much. So we can move on with the next speaker, Herbert Fryer, who's going to speak on the impact of COVID-19 on the survival of patients undergoing myocardial revascularization surgery. Oh, Omar. So it's Omar Mejia who is speaking. Sorry, it was wrong into
Morning. Thank you for approving our project. It's a Herbert Friday. Unfortunately, he's not here. Impact of COVID-19, the survival of patients undergoing CABG. The question is, will CABG protect patients from dying from COVID-19? This is our project to determine the impact of COVID-19 and the hospital period and follow-up for up to 3 years of patients underwent CABG. It's a prospective longitudinal observational study in a single center. 223 patients operated in CABG between March 2020 and February 2021. Interviews were carried out covering a follow-up up to 3 years after surgery to assess survival and time-free from COVID-19 infection. The AIR software was used, adopting a significance level of P less 0.05. It is of 212 patients eligible for follow-up. We reached 166 patients, more or less 78.3%, of which 26.5 tested positive for COVID-19 during follow-up. 76% of patients interviewed had received at least one dose of the vaccine in this questionnaire made. Patients who contracted COVID-19 during follow-up had a lower survival compared who were not contracted COVID-19. It's a significant difference. This is our Kaplan-Meier. In blue, we have a patient after CABG without COVID-19 in these 3 years. And in the lower, in red, we have patients with COVID-19. You can see a reduce in survival in patients contracted COVID-19 after surgery. Conclusion, COVID-19 significantly increased patient mortality, both in the hospital setting and in long-term follow-up, highlighting the critical importance of vaccination and other preventive measures to reduce the risk associated with infection. Thank you.
Thank you.
Thank you, Omar.
Any questions? Thank you very much.
Thank you. We'll move further.
Yes, Gianluca will present the impact of a dedicated training in revascularization surgery on coronary artery bypass grafting outcome.
This is Massimo Baldo, research fellow, great guy.
So,
Massimo, please.
Yeah, good morning, everyone. I will talk for my mentor, Dr. Torregrossa. So good morning, everyone. I will talk about the impact of a dedicated training in revascularization surgery on CABG outcomes. I have no conflicts of interest to declare, besides being truly inspired by my mentor, Dr. Torregrossa. CABG is currently the most frequently performed cardiac surgery procedure. However, differently from all of the other procedures in our field, it is basically the only one without a dedicated training. Very rarely have studies been published looking at the outcomes of a specialized CABG training. They have indeed shown how hospital mortality and operative times can be reduced, and this occurs despite the use of more advanced techniques. All of these issues have been elegantly discussed in this milestone paper, and the authors have shown how currently most cardiac surgeons still perform only conventional CABG. They conclude that more optimal outcomes in CABG can be performed with more advanced techniques. However, this requires a dedicated training. So the aim of our study was to analyze the CABG outcomes performed by a single surgeon who underwent specialized CABG fellowship trainings in all of its aspects and see whether these outcomes actually improve outcomes without impacting mortality. So from July 2021 to January 2024, all conservative patients in our centers from this surgeon were enrolled. We looked at postoperative outcomes and in particular also at a composite of cardiac death, repeat target revascularization, MI, and stroke. A total of 464 patients were included, and for the sake of time, please just bear in mind the predicted risk of mortality of roughly 1%. Outcomes were divided into open and minimally invasive surgeries, and you can immediately see how almost 92% of surgeries were performed off-pump in the sternotomy cases. More than 60% received a multi-arterial grafting, and composite grafts like Y, I, and sequentials were performed 20% each. For minimally invasive approaches, hybrid revascularization was performed almost 60%. Intraoperatively, conversions were extremely rare. Flows were very good at TTFM and postoperative outcomes minimal. In particular, hospital mortality at a 0.4%. Bear in mind the 1% estimated. On the left, you can see the Kaplan-Meier curve of the composite outcome, while on the right, there is the table with all the individual outcomes, which were characterized by very low rates. In conclusion, the study has shown how a dedicated training can actually improve CABG outcome. However, the surgeon must have undergone dedicated CABG fellowships. We indeed believe that there is a pressing need to establish additional coronary fellowships in order to enhance surgery outcomes in CABG worldwide. Thank you very much for your attention.
Thank you.
Thank you very much, Massimo. You are in training now?
I'm currently not in training. I'm currently a research fellowship. I will hopefully start my specialized training soon.
So any question from the podium? One question from me. You are not in training yet, but what do you think the one and the most important part in training for coronary artery disease? If you choose one and all the others.
So what do I want to see in my training program?
Yeah, one thing that you think is really important.
Wow. I think dedication. Truly passion on what you're doing. I know it may seem very difficult at first, frustrating, but if you're willing to accept all of these, all the initial problems, I think you can go everywhere.
Yeah, this is from you. I think from the training point of view, it should be very well organized, step by step, like you show in the graph. Yes?
Yes, I think congratulations, great training. One of the fellows 36 years ago in NYU, we have 500, 600 cases in 1 year, 2 years, just doing coronary, conventional. Now, we have much more technical complexity in addition to the conventional. What do you think? And actually, in your training, how much minimum requirement for each fellow to learn in a short period of time? There's no exact answer, but what do you think?
So I think,
yeah,
also if of course Gianluca wants to reply, but I think minimally invasive is the approach. I think first surgeons have to learn how to perform surgery, and then with that in mind, you can definitely apply it in a minimally invasive approach where you just have to learn the approach. I think this is also true for mitral valve surgery. You first learn how to perform mitral valve surgery, and then you can...
Yeah, in addition, I'm sorry, my question was not clear. Do you usually have a substantial training of conventional CABG in an ordinary fellowship?
No.
No.
It's a good point, and I will be brief. Reality is that in the practice where we practice, we don't have resident. And in one way, I'm accepting fellow. And, I'm also, this is my first year taking a fellow with me. He's a Japanese, actually, guy, and he's doing very well. But he's someone that has already spent some time, so he knows how to take down a memory, how to do sternotomy, how to go on bypass, and he knows some basics of distal on arrested heart.
You're top runner, you're creating things, so,
And, making him an off-pump CABG sternotomy, and he helps me with the robo, conducts the robo and exchange the instrument, and we are trying to make it through. The concept here is trying to say, we always say it's dedicated coronary should be dedicated pathway, but what are the outcomes? No? And effectively, as you see, you can go in a center that was a busy coronary center that was doing mammary clearance for everybody, and you can bring all of these techniques of pump, minimal invasive robotic.
I know. I think too many things we discussed, but I hear you. This is a very important topic.
Yeah.
Thank you very much.
Thank you.
For the interest of time, we'll move on with the next abstract, which is coronary artery bypass grafting outcomes using arterial grafts in hemodialysis patients from Mr. Watanabe.
Thank you. Good morning, everyone. Thank you for the opportunity to make this presentation. I have nothing to disclose. The number of hemodialysis patients in Japan is on the rise due to the aging population, and the mortality rate among them is also on the rise. When we examine the causes of death in these patients, cardiovascular diseases are the predominant cause of death among dialysis patients. Our department has actively used arterial grafts in dialysis patients, and today I will review our outcomes. The study included 135 cases of isolated CABG in dialysis patients over approximately 5 years. 58 patients received all arterial grafts, while 77 patients used saphenous vein grafts. The patient background is as follows. No significant differences were observed between the two groups, except for peripheral arterial disease. Most of the patients underwent off-pump coronary artery bypass surgery. The median number of grafts was 3.3 vessels per patient. Nearly with about half of them received bilateral ITA. The gastropiploic artery was used in approximately 25% of cases. In terms of postoperative outcomes, 30-day mortality occurred in one patient. Regarding complications, atrial fibrillation was the most common, followed by 2 cases of median stenitis, 5 cases of cerebral infarction, and 2 cases of non-occlusive mesenteric ischemia. However, no significant differences were observed between the two groups. The survival rates and MACE avoidance rates were comparable between the two groups, with no significant differences. However, the SVG group showed a trend to a declining survival after 4 years, and the MACE avoidance rate also exhibited a trend toward a decrease in the SVG group. In conclusion, we use arterial grafts in dialysis patients whenever conditions permit, and the results of CABG with active use of arterial grafts have been satisfactory. This approach may contribute to improving their prognosis. Thank you for your attention.
Thank you.
Questions from the podium? Yeah.
Yeah, I have a question.
Yeah.
Do you know what is, even for, when you have a dialysis patient, fistula on the left arm, do you use the Lima to the LED? Do you use the Lima to the OM? Do you use the Rita to the LED? What is the configuration? Does the potential stealing phenomenon when you go on dialysis that has been described change the construction of your graft or not?
Yep.
Yeah, I don't know if Minami is not here.
Yeah, sorry. Yeah.
Your
strategy. First of all, we don't use radial artery in dialysis patient because even if they are not on one hand, so.
Excuse me.
And we use the Lima to LED, but I don't know the result, the answer. Yes.
I'm a colleague from Tokyo, Japan, Yuki. And then so the next question, and then so that we don't care the lateral side or the shunt or not. Then so basically so that we focus on this using the bilateral. Yeah, it's not depends on the size.
Yeah,
Thank you very
we
much.
also use Lima to LED, and probably transit flow measurement is a good way to see if you have adequate flow. So if you have it intraoperatively.
Yes.
Sometimes when you go on dialysis, when they are at the time of dialysis, because they are suctioning off
Yeah.
your fistula, and there's been described a moment in which you can have ischemia of the anterior wall if you leave that.
Yeah.
But it was interesting to know. Thank you.
Thank you.
Thank you. So the next presentation by Vadim Popov, a comprehensive evaluation of the... Excuse me? Popov is not here. Okay. Okay. So Joshua Newman is here? Yes, please. Surgery or PCI first? 10 years outcome of hybrid coronary artery bypass grafting.
Good morning. Thank you to the Society for inviting us to share our work today. So I'll talk quickly about 10-year outcomes of hybrid surgery or PCI first. Doesn't want to advance. There we go. I have nothing to disclose. So we know for over a decade now that our societies have supported that hybrid revascularization is an option. Early on, it was just for select subsets of patients. But as we've progressed and things have advanced, we can see that more recently, the societies are supporting this hybrid coronary revascularization for almost all comers if it allows for total revascularization. Given the wider adoption of this approach, the question still remains with limited information, which do we do first? PCI of the non-corporate, non-LAD lesion, or the surgery Lima to LAD? So we set out to assess the impact of timing on the surgical component relative to the PCI on these hybrid patients. To do this, we conducted a 10-year retrospective review of our institution. We ended up with approximately 400 patients that underwent a hybrid revascularization. These were then propensity matched to 109 matched pairs in each group. We also quickly reviewed short-term outcomes of our most recent patients as well, just to see any changes that came out in that subset. For time today, we'll just focus on the propensity-matched cohort. You can see preoperative characteristics were well-matched between the two groups. Looking at operative information, we can see that surgical times were really not changed by doing a mid-cab first or a PCI first. We did find statistically significantly more patients had a left main coronary lesion as the non-LAD lesion in the mid-cab first group, and significantly more having a right coronary lesion in the PCI first group. Looking at short and long-term outcomes in this cohort, we can see that there were really no significant short-term outcome differences, 30-day mortality, stroke, transfusion, etc. Slight trend towards slightly lower length of stays in the PCI first group. And then looking at mid to longer term outcomes, we can see again, no real significant difference in either of the two groups depending on approach. This was at a median follow-up of approximately 9.6 years. At up to 11 years, our overall mortality rate was only 6.3%. That was of all-cause mortality. And you can see on the bottom there, in those patients that did undergo a Lima LAD first, at the time of stage PCI, we had a Fitzgibbon A score rating of a Lima to LAD interrogation in over almost 98% of patients. Just a graphical representation showing that out to 6 years out, really no significant differences in either propensity-matched or unmatched patients for MACE. Quickly just looking at our most recent data then, we can see here that the preoperative characteristics, again, pretty similar to what we had seen in the propensity-matched cohort. Outcome-wise, our short-term outcomes, if anything, improved shortly just with increasing experience, but again, not significantly different for any of the either of the two groups. The only thing that did meet significance was we had now a statistically significant shorter length of stay in those getting PCI first. So we conclude that both approaches, mid-cab first or PCI first, are safe and efficacious with excellent outcomes for total revascularization. But our suggestion and our preference is that given these similar outcomes, we prefer a mid-cab first approach just to allow surgery off of any DAPT, just to allow the surgery to occur off of any DAPT and to allow interrogation of that Lima to LAD anastomosis. Thank you.
Thank you very much. Thank you. Right on time. Question from the podium? Yes.
Dr. Kim from South Korea. Do you have any reason why, which strategy for us to do you have make any enquete or study about this? Why region? The reason why?
So why we prefer the mid-cab first? So thank you for your question. Our preference is mid-cab first because it allows us to intervene on that lesion and perform surgery off of dual antiplatelet therapy, which is one of the two main reasons. We have data in other presentations that have shown that at our institution it doesn't change outcomes to do the operation, but not all surgeons are comfortable operating on dual antiplatelets. Additionally, as you saw there, 98% of patients had the Lima I shouldn't say that. 98% of patients that had a staged mid-cab first were able to confirm perfect patency of the Lima LAD. The one patient that did not did have some stenosis at the anastomosis, and by performing this staged with the Lima first, we were able to intervene on that lesion at the time of the other PCI and stent that approach, so the patient did still end up with a perfect revascularization.
Another question, I do mid-cabs and few hip hybrid. I don't like to do mid-cab with my experience on the dual antiplatelet therapy. So how do you do it?
So it's just a meticulous technique. Our approach to it is no different. Most of our patients, like you mentioned, we prefer to do the surgery first. Most commonly, the PCI have been first because, as you saw, the right coronary was statistically greater involved. They came in, culprit lesion was the right lesion, they stented the right, and they have significant LAD disease. So it's just more meticulous approach, making sure that there's no bleeding at the time of mammary takedown. We lowered the CO2 to make sure that there was no venous that may have been tamponaded by a CO2 insufflation, and just very meticulous, really just meticulous surgical approach.
Thank you.
Thank you so much.
Thank you.
We'll move with the next speaker, enoximon administration to improve renal function in cardiac surgery, final results of multicenter observational study with enoximon in cardiac surgery. It's Dr. Zito, right?
Good morning, everyone.
Good morning.
Thank you very much for the introduction and for the opportunity to speak here today. I will be talking about a study we did titled Enoximon Administration to Improve Renal Function in Cardiac Surgery. And to provide some background, we know that the postoperative renal failure can be a major issue in cardiac surgery, which is strongly associated with the cardiopulmonary bypass use and its duration. So many techniques have been proposed to avoid this risk of renal failure, such as the off-pump surgery and the use of anti-inflammatory agents. Therefore, the aim of our study was to investigate the impact of the enoximon administration on renal function in patients undergoing on-pump cardiac surgery. So this was a multi-center observational study with enoximon in cardiac surgery. The preliminary results have been already published in 2018. We implemented the cohort of patients, including patients undergoing coronary artery bypass grafting surgery that were prospectively collected. So the preoperative evaluation was assessed by calculating the eGFR using the CKD-EPI equation. And as we can see here on the right of the slide, the CKD class was also assessed before surgery. After the operation, the eGFR and its delta variation was calculated at day 2, 7, and 30 after the operation. The renal failure was defined as a decline in the eGFR more than 50% from baseline or the need of dialysis. So in the end, this study included 232 patients that after the propensity score matching ended up in 2 cohorts, including 160 patients each. So as we can see here in the slide, there were no major changes in the percentage of the delta eGFR evolution at day 2 and 7. However, as we can see here at day 30, patients undergoing enoximon administration had a higher percentage of increase in the eGFR, resulting in a 5.1% compared to a decrease of minus 3.9% in the control group. So this slide shows the changes in CKD class variation between the preoperative period and the postoperative period. As we can see in the picture on the left, patients undergoing enoximon had the more improvements compared to the control groups, as more patients moved from class 2 to class 1 and from class 3 to class 2. In the control group, on the right, we can see that patients either stayed in the same class or have worsened compared to the enoximon group. So to investigate factors associated with the delta variation at 30 days, we performed a multivariable linear regression that showed age, BMI, the preoperative EGR, and most importantly, enoximon to be positively associated with the delta variation at 30 days. So to conclude, our study found that patients undergoing on-pump CABG may benefit from this perioperative administration of enoximon. The renal function significantly improved at 30 days in the enoximon group. However, the patient selection remains crucial in identifying those who may benefit from this treatment. Thank you very much.
Thank you very much. Here's one question from Dr. Tagger.
Yeah, hi. Thank you for a very nice presentation. a bit confused about this. I remember when I was a senior registrar at the Brompton 25 years ago, when we started giving patients routinely enoxamine, we killed many of them. They completely lost their peripheral vascular resistance and then needed enormous doses of pressor support to get a blood pressure back. So I am very, very cautious about it. And in the odd patient where it may be indicated, my view to my anesthetic colleagues is don't start it with bypass because it has an unpredictable effect on peripheral vascular resistance. If you really want to use it in the post-op period, get the patient operation done, get them off bypass, back to intensive care, and then introduce it very gradually. But I've seen catastrophes with these. So my basic question to you is, did you notice any problems with enoxamine on peripheral vascular resistance?
Well, we actually did not. There were some cases, of course, but I mean, the one of the main fact that can impact our study is the lack of randomization. So we actually don't know the real mechanism underlying the benefit of the enoxamine.
But just in terms of, do you have any data on the amount of pressor support that was required in the two?
That's an excellent point. Thank you very much. We do not, but it's something we should investigate maybe.
It'd be very worthwhile looking at it. But thank you for a very nice.
Thank you very much.
Thank you.
Thank you. Thank you very much. Hoshun Chong from China, timings matter. Unveiling the impact of drainage tube removal on atrial fibrillation post-CABG, a decade of drainage insights.
Good morning. Hoshun Chong from Nanjing, and this is my slides. Now, we know that in thoracic surgery, it's much obvious that they got a very specific drainage before they can remove the tube. It's like 450 per day, 24 hours. But in the cardiac surgery, it's actually less clear if rapidly removing the chest tube is equivalent or superior to leaving it. Of course, there are studies showing that their earlier removal is better, and there is something that's against it. So ERAS told us that we should remove the chest tube earlier. Yeah, it's fine. And a bit earlier.
You're not seeing.
Yeah, it's fine. And so we know that POAF actually happens a lot after cardiac surgery, and especially in CABG patient is over about 20%. It's rather a high rate that happens in a lot of patients, and it's a very dystrophic morbidity. It increases length of stay, it increases penalties if there are DRGs, and increased readmission is a big medical liability risk for us. So how we do it, we put a 26 to 28 French drain, place it at diaphragmatic plane next to the apex, and put a negative pressure about -8 to -10 centimeters of water. And we in the patient for us, we separated into a delayed group and a normal group, which is around because we find that the mean day of tube removal is about 3 days. So we separate these these two sets of patients, and we make a PSM, and we find that the POAF actually seems like there's a 23% of reduction happening. And so when there's a longer period of tube placing inside the body of a patient, we worried about problems like infections. From what we see, it doesn't actually increase the upgrade of antibiotics, so probably it doesn't cause us any infection after a delayed or prolonged tube placing in it. And the hospital stay, actually what we find is that if patient requires an additional paracentesis or thoracentesis, it actually increase the length of stay, but otherwise, it doesn't really matter. Because in China, it's quite different. I know from US, like when I've been in Hopkins and MGH, patients after discharge, they might go to nursing home or other places which can cause, and a lot of patients actually see the cardiologist instead of coming back to cardiac surgeon. But in China, there's a different case that patients, they stay with you lifelong. They come back to you all the time. No matter even a cold, they will ask you for advice. So that's how we find the patients. And another problem that we actually worried about is the mobilization of patients. The placing tube for us is actually quite light, and there's another problem is the pain problem. Is if the pleural cavity is open.
You have to.
Very fast. Inserted, it will actually increase the pain intensity. So what we were trying to say is that delaying a removal tube actually continuously drainage of the fluid, it reduces POAF, potentially reduce post-op infection and what you can see. And when we are trying to harvest the lemur, we try not to open the pleural cavity, and we believe that it helps with the pain problem, so patients will be getting a better, faster recovery. Thank you. Sorry for time.
Thank you very much. Actually, it's a very interesting question, when to remove the drainage, and I would have to know other people. In my center, because of routine, usually 36 hours, and we take the drain out. And sometimes if there is in the X-ray too much fluid, then we leave it more, of course. But the routine, and I wonder whether we should leave it a bit longer, of course, with the pain and all the other. Any people from the podium, what is the routine in how long you leave the drain in? Do you leave looks in the X-ray before you take them out?
Yeah, no, very interesting point. IRAS, tomorrow we will speak about drainology and the science, and can we do something better than what we have always done with this Pleurovac? I don't have a solution. I'm the type of guy who have been training, who like to keep the chest tube forever. Even if I like to see it dry before I remove it, but I don't know if it's the right thing. We need more science.
Yeah, for us it's 100 milliliter per day. Yes, because
I also inject a chest tube. I don't know if you guys, I learned from my wife to describe the technique. If it's less than 100 ml of blood coming off from the chest tube already in day 0, 2 hours after the patient is in the ICU, is extubated, we clamp the chest tube for 15 minutes. We elevate the chest tube. Patient has to be laid down in bed. Take a syringe, put some chloride, and I inject a solution of 20 ml of bupivacaine, 4%. And there is a 70% of patients that complete like a lot of pain. You decrease the pain from 10 to 2. I've done in Lima, no problem with wound infection, and we do it max of 6 times a day. That's
I just have one question. Did you do in your cohort, there is the PALOX study that was just published in Lancet, that if you do a posterior pericardial,
yes,
that might reduce. Yes, do you use that? Would be that an option to combine low-ink atrial fibrillation with earlier?
Yes, from what we see, I know there's a trial coming out soon, also starting from 2023, I guess. The problem is the pericardial, and we are worried about other causing of like the phrenic nerve and the hernias of the heart. This is what we are worried about. Okay. And another problem is that from what we see is that if you put a pericardial, for posterior pericardial and the incision, you need to drain it into the pleural chest. And it might possibly causing, because in China, actually, I'm not sure that if anybody have operated in China, patient in China tends to be wetter than what we see in the Western country. So if you put a posterior pericardial incision, that is most probably that everything is going to leak down into the chest, the pleural cavity, and then ends up that we need to put in the chest tube into the pleural cavity. And what we see is that it's causing much more pain for the patients. It seems like they are much more intolerable for the pleural cavity.
So you don't do it on a regular?
We prefer not to do that. Yep.
Okay.
We have to continue.
Yep.
We're a little bit behind. Experience in coronary surgery, in cardiothoracic surgery, graduation in the United Kingdom, Jeremy Chan.
Hi, good morning. Thank you for the opportunity to present my work. I have no disclosure. I don't think there's a lot of things we know in the literature about the experience, i.e. our surgical logbook that is published in the literature, particularly in Europe. And we know that this is a graph in the UK, that the number of cases performed by trainees are gradually going down and down. So we aim to evaluate the number of procedure trainees have done over their training program in the 7 to 8 years in the UK. And a quick summary of the UK training. We've started on the top with 2 years of internship, 2 years of basic surgical training, followed by 6 years of specialty training in cardiothoracic surgery. But we've moved on, similar to the US, we're now using an integrated system where after a 2-year internship, we go straight to a 7-year program, and trainees are expected to do 250 cases by the end of 7 years. But whether it's feasible or not, we don't know yet. It started only in the early 10 with very limited candidate, and after 2022, it's become the sole pathway, so the upper pathway is completely gone. So using the old traditional pathway, the 6 years, we'll see whether trainees can do 250 cases by the end of 7 years. And after exclusion criteria, we've ended with 99 cardiac theme trainees in the summary of this project. So the 6 year traditional program in UK actually took 7.5 years for most trainees to complete. And the median number of cases logged by trainee was 247, so approximately 250 cases that was expected in the new integrated curriculum. And out of the 250 cases, approximately 70% were coronary artery bypass grafting, followed by valve, with majority being AVRs, and followed by mitral. But one thing is probably not the cover for this conference is most trainee or most graduates can only perform CABG and AVR, but we're expecting them to go straight from day one to do dissection, which they have very limited exposure to. So this is something that is worrying. But regardless, I think 200 coronary cases over 6-7 years is still a very good number. And we need further research on comparing the integrated and the traditional pathway. Thank you.
Thank you.
Thank you very much.
For the sake of time, we'll move on with the next speaker with the topics of claving arteries and alternative inflow to coronary artery surgery in OPCAP. Dr. Kim.
Thank you. I'm Dr. Kim from Veterans Hospital, South Korea. First of all, regarding the first presentation about the Group 1 complete revascularization instance, not 30%, but 70%. It is my error term. I'm sorry. Today, I'm nothing to disclosure. In terms of inflow feeder to coronary target, intrathoracic and aorta are the frequently used worldwide still now. We have been tried subclavian artery inflow when redo CABG and minimally invasive OPCAP, and presented this work at the last ICC meeting and New York meeting. During recent 2 years, we have been extending this approach more in the, especially in elderly, more than 75 years old, and also in friar patient. So this is the case series about this approach. Yeah. As you can see here, initial 2016, during the first 5 years, all cases are redo cases. After confirming the stability of the redo cases, I expand this strategy to the very elderly and priority patient. So in this study group, including 35% redo cases, and their median age is 76 years old. This patient's characteristics, it is recently updated. So mean age is 76 and octogenarian is 13%. Left main 3 vessel, prior MI, PCR, redo CABG, and second redo CABG also we have. And there, even the critically ischemia and bedridden patient we also have, and empty and sharp patient we have also. Yeah. My OP method is the prostatectomy or even the minimally invasive first redo and second redo. It is no difference between them. And recently, my big change is the harmonic scalpel usage to skeletonize the harvest of the old conduit. So no more metal clip, like you can see here. And OP cap strategy, grafting preference is the I used the inside tube, more multiple inflow and complete revascularization as possible. And we make the pericardial closure as possible. And some posterior pericardotomy only when the on-pump CABG. This is my recent cases, as you can see here. December 6th, I conducted four bypasses, like you can see here. And this is a 5-day post-operative CT image. Their perioperative result, as you can see here, their operation...
3 minutes, you have to go, 3 minutes.
Yeah. So the number of anastomosis is 3, and so on, as you can see here. The pericardial closure is about 70%. The transfusion is only 1, and extubation ICU stay, discharge is usual, as you can see here. The complications look so high, but recently it is improving rapidly, good. And so the survival function, it is not updated yet, so it is reasonably acceptable. So I recommend you try it carefully for the very elderly and very frailty patient. It is very helpful, I think. Yeah, it is my question. Thanks for your attention.
Thank you very much. Since within 7 minutes someone else have to be here, so we'll have to continue immediately. The next presentation is from Angus Gerald Peter Jones from New Zealand, comparing clinical outcome between sequential and separate coronary artery bypass grafting.
Hi, my name is Angus Jones. I'm a medical student from the University of Auckland in New Zealand. Firstly, thank you to Dr. Krish Chowdhury, who supervised this project, and ICC for the opportunity to present today. So debate lingers around the optimal CABG configurations, with many surgeons adopting a one-size-fits-all approach to their patients. Literature also suggests that long-term sequential graft patency is superior to separate grafts, but is more technically demanding for the surgeon. Additionally, literature suggests that sequential grafts should be arranged to bypass the most severe stenosis distally to avoid competitive flow and subsequent graft occlusion. However, to the best of our knowledge, no literature exists investigating clinical outcomes in this context. The aims of our study to compare clinical outcomes between separate and sequential grafts, and then further to analyse between sequential grafts where the notion that the most distal target bypassed should have the tightest stenosis was respected or not. This was a single-centre retrospective cohort study. We analysed 1,500 consecutive patients who underwent isolated CABG operations from 2018 or earlier at Auckland City Hospital. This provided us with a greater than 5-year follow-up period. Participants within the sequential group were further grouped for secondary analysis based upon the percent diameter stenosis and whether the tightest stenosis bypass was also the most distal. Results from our study. Comparison of the separate and sequential groups on the left-hand side using Kaplan-Meier plot showed a decreased survival probability in the sequential group over the time points. There was also a 3.6% higher mortality in the sequential group, but this was not statistically significant. On the right-hand side, comparing the sequential non-respected and respected groups, there was no significant difference in survival probability found between the patients receiving sequential grafts where the most distal target was also the tightest or not. Overall mortality was 1% higher in the non-respected group, but this was not statistically significant. So conclusions we've drawn from our study today. Firstly, there was reduced survival probability in patients receiving sequential CABG compared to separate. Secondly, respecting the notion that the most distal stenosis bypassed is also the tightest showed a slightly improved mortality of 1%, but this was not statistically significant. And lastly, we believe that future studies should examine the impact of functional assessment of stenosis, such as FFR and IFR, rather than perhaps cardiologists eyeballing the percent stenosis.
Thank you so much.
Thank you.
We'll move on with the next speaker, Dr. Chan, preliminary experience of a multicenter retrospective study in the use of 4 arterial grafts on complete arterial revascularization in patients with triple vessel coronary artery disease in China.
I'm from Wuhan, China, so the China, this is our fellow doctor in different hospital. In China, the total artery is still very low, the use very low. Low than in the U.S., low than Australia, low than Korea, low than Japan. So complete revascularization and a total artery has been widely accepted to have long-term clinical outcomes. So lead evidence shows that whether 4 arterial graft can prove better, but patients' revascularization have a satisfactory effect. So this is arterial conduit in triple vessel disease. So my is the bilateral mammary bilateral radio in my study. We have choose the size of radial artery. We need to check the IMA quality of before surgery. So this is a Doppler Allen test, and we do each case do the Doppler Allen test. So we also check the bilateral IMR CTA before surgery. So we do the open, pedicle, and no touch. So we harvest the right mammary from the second intercode space to the bifurcation. So left mammary is inserted. So we can see the right mammary we harvest free. So we do the on pump. The Lima is usually the LD. The left radial is to the PDA-PL or RCA. The right artery, right radial is to OM diagonal or Remus. So we do the on pump each case. We use the lido cardioplegia. So we do the ultrasound filtration. So we have very good data. So this guy is very good life quality. So we also do the CTA. This is the free Vima. We do the T graft with the radial in the left heart.
3 minutes.
Okay. So this means baby white graft, in right coronary, there's a baby white graft in left coronary. So we will use 4 arterial graft, more complete arterial revascularization. For in South China, the single is better than Y. Y is better than sequential. In South China, the population is more size than the lost.
You have to conclude.
So the quality is control. You can do that. See that.
We have to move on, probably.
Yeah, you can see that it's a very good quality. So, atrophy titration is necessary for each case. So, complete arterial revascularization in patients can be done with both bilateral radial, bilateral mammary. So, in our study, we have proved safe and effective in select patients. Thank you.
Thank you.
Thank you. Since it's really 8 o'clock, we'll call the last abstract for the morning. Hong Jung Yong from Glasgow. Outcome of purely internal thoracic artery, coronary artery bypass grafting in patients 50 years and younger.
Thank you.
Hi, I'm a medical student from the University of Glasgow. I'd like to thank my mentor, Professor Nawar, and the Society for this opportunity. I have no disclosures. So the long-term results of CABG utilizing bilateral ITA continues to generate debate. Young patients potentially have the most to gain. Young patients generally have the most to gain from prolonged patency of bilateral ITA revascularization in terms of increased life expectancy. Studies suggest improved long-term survival in young adults than in older patients for conventional CABG, with no specification regarding conduit selection. However, there remains limited data regarding long-term results after total arterial CABG in young patients. So the technique carrying out in our center consists of complete extrapleural skeletonized harvesting of bilateral IMA. The fascia is excised while the internal thoracic veins are preserved in situ to preserve a degree of revascularization to the sternum. The right IMA is dissected at its origin point and connected end to side to the in situ left IMA in a Y-shaped configuration. Anastomosis is conducted in a sequential manner, either in an end-to-side or end-to-end manner, depending on the target coronaries. So the standard practice for surgical wound management include the exclusion of bone wax, sternal fixation, extensive intraoperative hemostasis, vancomycin paste for all patients, and negative pressure wound therapy as indicated based on Fowler's score that we conduct post-op. So here are our methods. We identified 91 patients aged 50 years or younger between the years April 2012 to March 2023, the exclusion criteria being CABG with grafts of less than 2, concomitant major cardiac procedures such as valve surgery or aortovascular surgery. The relationship between Euroscore, LV systolic function, BMI, diabetic status, pulmonary disease, and extracardiac arteriopathy prevalence and survival were investigated using survival analysis methods. Univariate analysis was carried out, followed by a multivariate Cox regression model constructed using stepwise variable selection to determine independent predictors of survival. So here are our results. 86.7% of our patients were male, with a mean age of 45 years old, and each patient received, on average, 3.6 grafts, with most patients receiving either 3 or 4 grafts. The average cardiopulmonary bypass time was 7.71 minutes, and cross-clamp time was 60 minutes. The survival for our population was 97.8%, 96.5%, and 91.9% at 1, 5, and 10 years respectively. There were no reported deaths within 30 days, and the one-year mortality rate was 2.2%. And we only had 1 patient with a reported deep sternal wound infection, and there were no incidences of new onset hemofiltration due to AKI post-op, and no post-operative cerebrovascular accidents. There was evidence of a higher risk of dying associated with a lower BMI, and LV function was also a significant factor associated with survival in the univariate and multivariate analysis. For LV function, the hazard of dying for those with moderate or poor LV, which is defined as LVEF of less than 50%, is 10.2 times the hazard for those with good LV function of more than 50%. So in conclusion, this study reveals no operative mortality rate for younger patients undergoing purely internal thoracic artery CABG, with an excellent midterm and late survival, with low prevalence of surgical site infections following an effective SSI bundle. Patients with compromised LV function were identified as having a notably increased mortality risk, and employing the PITA CABG can confer a survival advantage for younger patients requiring surgical revascularization of the myocardium. Thank you.
Yep. Thank you for this presentation, and thank you everybody for attending this session. There was very, very good interest, so we were 5 minutes late, but they were excellent presentation. I wish you a productive and interesting day.
Thank you.